Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, how are you? I'm Susan Kaufman. I'm here for Attitude Magazine, and you're listening to Attitude's ADHD Expert Broadcast. One of the most difficult aspects of attention deficit can be finding a medical professional who's qualified and able to correctly diagnose both ADHD and its coexisting conditions. We've talked often about coexisting conditions, very common with ADHD, and even once you have a correct diagnosis, establishing an effective treatment plan can be, frankly, no small challenge. So today we're especially pleased to welcome back Dr. William Dodson to discuss ADHD diagnosis and treatment, mistakes that doctors often make. Dr. Dodson will tell us why ADHD is often misdiagnosed as anxiety, as bipolar disease, as OCD, or another disorder, and he'll also take your questions and talk about common medication pitfalls and how to avoid them. You may have heard Dr. Dodson speak before. He is a member of our advisory board. We value his opinions enormously. He's a board-certified adult psychiatrist. He's specialized in adult ADHD for over 25 years. He's in private practice in Denver, Colorado, where he's a life fellow of the American Psychiatric Association and the recipient of the Maxwell J. Schleifer Distinguished National Service Award for his work with people with disabilities. His upcoming book is titled What You Wish Your Doctor Knew About ADHD. And for more information, please visit www.dodsonadhdcenter.com. Thank you so much for joining us today, Dr. Dodson. We are always grateful for your time.
Thank you, Susan. ADHD is extremely common. The CDC says that about 10% of people worldwide, anywhere you look in the world, will have an ADHD-style nervous system. People with ADHD tend to concentrate, however, in mental health practices because of the high rate of coexisting psychiatric conditions. 70% of children, adolescents, and adults with an ADHD nervous system will have at least one other psychiatric diagnosis. 57% will have two or more. So about 1 in every 5 people who walk into a mental health office is going to have ADHD. The problem is that the diagnosis is routinely missed. And that's because very few physicians, whether they're in the mental health field or anywhere else, have any training whatsoever in ADHD. Even psychiatrists have very little. About 93% of psychiatry residencies don't mention ADHD in 4 years of training. And as many as half of pediatric residencies give absolutely no instruction or supervision on how to treat children with ADHD. You can also see this in the National Comorbidity Survey Replication. That's a real tongue twister. It's a huge study done every 10 to 12 years, in which they look to see how many people have which diagnoses, and they interview about 10,000 people. And this last time it was repeated, they included ADHD for the very first time. And what they found was that, again, about ADHD was extremely common in adults, and that only about 1 in 10 adults had received any treatment at all, medication, cognitive therapy, or anything like that in the previous 12 months, but that 43% had sought mental health treatment during that same time, and the diagnosis had been missed. So if anybody says to you that ADHD is overdiagnosed and overtreated, you need to say, no, that's just not true. In point of fact, there's no evidence that shows that we pick up as many as 25% of what's actually out there. And even if we do pick it up, most people are grossly undertreated. Most psychiatrists, adult psychiatrists, have no preparation at all in ADHD. There has never been a single question on the board certification exam for adult psychiatrists on the subject of ADHD. So it's something that's generally just ignored as if it weren't there. rather than present in 1 out of every 5 people who are going to walk through the door. So let's talk briefly about the most common diagnostic mistakes that physicians make, whether they're psychiatrists or general practitioners or PhDs. The biggest one is the doctor never even thinks of ADHD. It never comes on the radar screen. It is very rare that I see a patient who was diagnosed by a medical professional. Almost always the diagnosis is a self-made diagnosis by the patient. And again, this is because ADHD is so genetic that half of a person who has an ADHD nervous system, half of their first-degree relatives are going to have ADHD, and usually the person has to figure it out on their own. Every teacher they've ever had failed them, every physician they ever had failed them. Easily 90% of adults have to make a self-diagnosis. The other thing is that the whole notion that ADHD is some sort of brain damage persists despite mountains of evidence to the contrary. And so a lot of physicians think that anybody who has succeeded either academically or occupationally couldn't possibly have ADHD. Many physicians equate ADHD with some sort of mental retardation. The actual truth is that people with ADHD are much brighter than the general population. The average IQ of people with ADHD is 122. All the IQ necessary to go and get a doctoral degree, an MD, JD, PhD. So it really tells you also how much ADHD does get in the way of many people. The third thing that happens is that doctors, and especially psychiatrists, because they don't know anything about ADHD, tend to recognize what they do know. And almost always that's some form of mood disorder, and usually they diagnose a bipolar mood disorder, either not otherwise specified or atypical bipolar disorder. The reason for this is that people who have an ADHD nervous system lead very intense, passionate lives. They tend to have very strong emotional reactions to the events of their lives. But it's very easy to distinguish a mood disorder from ADHD. Any mood disorder, whether it's major depression or bipolar or dysthymia, has certain features. And one is that the moods don't have a trigger. They come and go for no apparent reason. The onset is very gradual, over weeks to months. The person has absolutely no control over the mood. They can't lift it. They can't make it better. In fact, usually they can't even make it worse. And by definition, a mood disorder has to persist unchanged for at least 2 weeks. ADHD couldn't really be more different. Virtually always, people with ADHD are able to look back and say, I can see the trigger literally every time. And my mood shift matches my perception of what that trigger was. The mood shifts are instantaneous. In other words, these are normal moods in every way except their intensity. The difficulty comes when you do have the overlap with somebody who does have ADHD and a mood disorder. And there, again, the way you can separate the two is ADHD is lifelong. You can see the manifestations of ADHD being consistently there all the way back into childhood, whereas mood disorders almost always have a much later onset of symptoms, usually between the ages of 16 and 20. Many doctors misinterpret the hyperactivity and hyperarousal of ADHD as anxiety. And here, very commonly, the ADHD patient helps them make that misapprehension. They come in and say, Doc, I am so anxious. When somebody tells me that, my next question is, can you tell me more about your baseless apprehensive fear? which is the definition of anxiety. In other words, people have this feeling as if something awful is just about to happen. That's what anxiety is. Usually when I ask somebody to tell me about their baseless apprehensive fear, they look at me very quizzically and said, well, I never said I was afraid. I said, okay, well, toss away that label of anxiety. What are you using that to describe? And almost always what I'll hear is, Doc, I can never slow down. I can't watch a TV program with the rest of the family. I can't turn my brain and body off to go to sleep. I am constantly going. So what they're really describing is the hyperarousal of ADHD that does dim down in adolescence, but it doesn't go away. It just turns inside. Many doctors also mistake the fact that people with ADHD, in order to cope with a fairly random, scattered lifestyle, do develop fairly rigid structures and ways of doing things, and this is misinterpreted as obsessive-compulsive disorder. And again, the major distinction there is that by definition, obsessive-compulsive disorder, the rituals and the things that people think and do have no purpose. They're kind of magical. And they really deplete the person's energy, draws away their attention from other things, and really can take over their lives. Whereas for a person with ADHD, this structure, the rituals, the habits have a very adaptive purpose of helping bind the ADHD. About 90 to 95% of adults with ADHD are going to report severe chronic insomnia. This is due to the fact that when the hyperactivity of ADHD does dim down in adolescence, it doesn't go away. It shifts to the nighttime, becomes tied to sunset, so that about 90 to 95% of adults with ADHD will give the following history. They'll say, Doc, I'm a night owl. I've always been a night owl. When the sun goes down, everybody else is getting quiet and ready for bed. I get a burst of energy. And that burst of energy is the hyperarousal of ADHD suddenly coming back. And most people with ADHD find that they physically toss, turn, can't get comfortable, and their thoughts bounce from one concern and worry to another. The average length of time is more than 2 hours every night. Unfortunately, many people will tell the doc or the psychiatrist, my thoughts race at night and keep me awake. And on that use of the word race rather than bounce or jump, get put on lithium as if they were in a mania. Once doctors finally do make the diagnosis, and usually it's the patient telling them the diagnosis, they still have trouble with treatment. Most doctors think that the medications used for ADHD are the treatments of last resort when everything else has failed. And that indeed is part of the problem, is that as we stand right now, nothing but the medications have shown consistent, lasting benefits. All of the behavior modifications and cognitive behavioral things and stuff like that, diet manipulations, megavitamins and stuff like that, haven't shown that they have lasting benefit. So all of the standards of care list the ADHD stimulant medications as the first-line treatment of choice for ADHD unless there is some compelling reason not to use them. The second biggest problem is that while they theoretically know they can prescribe, the doctor keeps waiting and waiting in hopes that somehow ADHD is just going to go away on its own. The hope is, well, he'll just outgrow it. This was indeed encouraged, again, because when hyperactivity did dim down in adolescence, doctors did hope that, well, he's no longer hyperactive. He was just immature and grew out of it. In point of fact, ADHD is now well known to be both genetic and neurological. And since no genetic disorder goes away with age, and no neurological disorder goes away with age, it is somewhat silly to think that people with ADHD will somehow grow out of their ADHD. I've never, in 40 years of practice, had a single person say, gee, I'm glad I waited that extra decade. Instead, what I hear almost universally is a profound regret that I didn't do this years ago. Once a doc finally does decide to try medication, one of the biggest problems, one of the most common problems, is that they try one medication, and if that doesn't work, that's the end of it. They never try another one. We have, at the last count, 26 first-line stimulant medications that are FDA approved for the treatment of ADHD. But all 26 of those products are just different ways of delivering only two molecules. There's the methylphenidate group, of which Ritalin is the one that most people recognize the name of, but that's Concerta, Focalin, Metadate, all of those. There's the amphetamine group, which is Adderall, Vyvanse, Dexedrine, all of those. Everybody seems to have a very clear preference for one over the other, but nothing predicts that in advance, and it doesn't run in families. If you had 100 people with ADHD and you started them on whichever stimulant you were feeling lucky with that day, 70% of them are going to have a very robust response to that medication. But that means that 30% will try that medication and not get any benefits at all. They'll only see side effects. When both methylphenidate and amphetamine are tried, 88% of people get that, oh, wow, where have you been all my life type response. But again, that still leaves 12% of people who have tried both amphetamine and methylphenidate and still do not get a robust response or only get side effects. So the whole process is one of trying to optimize medication. And I give everyone a trial on both amphetamine and methylphenidate, because even if I get a good response with the first one I try, for all I know, I might get a great response with the second one. These are medications that a person potentially can take all day, every day for the rest of their lives. So it makes sense to me to up front put in a couple of extra days to make sure that we've got all that medication has to offer, especially since medication for the last 15 or 20 years is pretty much what we have to offer. If you look back in the studies of how physicians actually practice, one of the most common patterns is that physicians will start a stimulant medication and they'll increase the dose up to the first sign of positive benefit and then stop. In fact, that's the 90th percentile. 90% of physicians stop at the first sign of positive benefit and never optimize the medications. The other problem is that if they're in that 30% who don't get a positive response, it basically scares the doc and they stop trying at all. And they stop using medication at the first sign of any difficulty. Finally, especially with children, many doctors are still in the habit that they were taught back in their residency of dosing the medication according to a child or adolescent's weight. There is absolutely nothing that supports this practice. It's been disproven in 6 very good double-blind controlled studies. In fact, absolutely nothing predicts which molecule a person will get their best response to or which dose a person will get their optimal response and no side effects. You just have to try them. Dose does not vary according to weight, height, gender, scale scores, severity of impairment. Nothing at all predicts dose. You just have to try it and see. So, with those opening remarks, I will open it up. And Susan, I hear you already have a whole bunch of questions waiting.
I do. I wanted to step back to the diagnosis issue. It seems so difficult for people to get a good diagnosis, and we have a number of people on the webinar who give examples of a child who clearly has a parent with ADHD and yet has been only diagnosed with depression, and what should they do, and so forth. What steps should a doctor who's knowledgeable about ADHD take to get an accurate diagnosis? What's the actual process that people should look for a diagnosis?
With children and adolescents, first thing you want to do is you need to pull out a checklist of the DSM-5 diagnostic criteria. They were originally designed for children. They are excellent. They are 98% accurate. In other words, better than any other diagnostic set that we have for children. The problem is going to be that if you look at the diagnostic criteria, they are things that we all have done at one time or another. We all have faded off and not listened to other people. We have interrupted other people. We've misplaced things. They're all things that everybody does. So you have to remember that the 18 criteria are just one piece out of 5 that you have to get the diagnosis. You have to have 6 out of 9 of either the first 9 and the second 9, but also these features must be consistent, persistent, pervasive, and impairing. They have to be consistently there all the time. They don't come and go. They have to be persistent. In other words, they have to have persisted all the way from childhood, as far back as the person's memory goes. Pervasive. It doesn't happen just at school. It happens at school and on the playground and at home and while doing homework. It happens pretty much everywhere. But the most important thing is that these are more than just lovable little traits and quirks. They have to cause significant impairment, and in pretty much every area of a person's life. And so that has always been one of the controversies, is that if a person works twice as hard for half as much, they work much more than their peers, the parents have the money to get tutors and things like that, and so with superhuman effort they are able to keep up in school and things like that, that still counts as the impairment. You're able to compensate for it, you're able to find adaptations, but it's still something that needs to be treated. So you have to meet the diagnostic criteria, and then also look for other diagnostic entities, which you're going to find 70% of the time. So most of the time, it's an ADHD plus diagnosis. It's going to be ADHD plus depression, ADHD plus anxiety.
There are some other diagnostic techniques that people have read about. There's let me see this, the NEBA diagnostic technique. There are scans. There are eye tracking studies. Any of those alternative or additional methods to rating scales have been useful in your experience?
No, and they are discouraged by the most recent standard of care comes from the American Academy of Child and Adolescent Psychiatry, and you can download it from their website. It's in the public domain, and they very specifically say these things really don't have anything to offer in the diagnosis of ADHD or in monitoring treatment, and they particularly say scans such as functional MRIs, SPECT scans, PET scans are to be avoided because they really have nothing to offer in the diagnosis of ADHD, and they unnecessarily expose people to significant amounts of ionizing radiation. So all of these standards of care actively recommend against scans.
So in your view, the rating scales, the tracking of symptoms are the most important measure for diagnosis.
Right. The ACAP guidelines are very clear that ADHD is a diagnosis that's made on the basis of a well-taken history.
Okay.
And again, that's the problem, is that it requires the doctor to slow down, take time, and take a good, careful history, which usually takes an hour and a half, which most docs don't have to give.
And sometimes I think the rating scales are given to teachers, to other people. Is that a common technique?
Yeah, now you want to get corroboration if you can, if it is available. One, it's very good feedback about, is the child having the same sorts of problems everywhere they go, in class, on a sports team, on the playground, at home. And if you had one person in the world to ask, the most reliable informant is going to be the teacher. That second grade teacher has been teaching second graders for 20 years. She knows what second graders are supposed to look like. So usually the teacher is the most reliable source of information. If the parents are divorced, then the divorced parents will always give you two totally different pictures, and so it's nice to have the report from the teacher.
Interesting. I mean, I think one of the problems that we hear frequently, and there have been some posts to this effect, is that where one parent just chooses not to believe in ADHD, they're looking for some compelling diagnosis. I mean, there's no blood test. There's no, there's something to say to that parent, yes, this is definitely ADHD. Do you have any advice for that parent who's trying to make that case based on rating scales?
No, because it's not something that is usually available to rationality. Mm-hmm. The person just doesn't want to know about ADHD. Right. Many times, they don't want to let the person off the hook. Is usually the way it's put.
Moral
they want to see They see it as somehow the diagnosis of ADHD is an excuse for failing in school or bad behavior or something like that, rather than an explanation. And these are usually very punitive people. They want that child, adolescent, or adult to be punished for their failures. They're usually very mean-spirited people, and they're never going to be persuaded. So you just have to go on without them.
Right. Tough for some parents. Here's an example of diagnostic dispute. My son's been in the behavior learning center at school with a special ed teacher of 20 years experience who said my son does not have ADHD. But both the doctor and the counselor say that he does. Who should I believe? Other teachers say it looks more like anxiety. So that's the kind of thing that comment, which is posted here, I think, is a situation that a lot of people find themselves in. He said, she said, some people say it is, some people say it isn't. I mean, it's a very difficult way to live.
It is, and I would ask that teacher, what do you base that on? I wouldn't just say yes or no. And that sort of brings a very quick digression. The fact that nothing has been working other than medications has meant to a lot of people that we have for a long, long time been missing something both huge and fundamental about the very nature of what ADHD is. If you ask most adolescents and adults who have an ADHD nervous system, think back over your entire life. If you've been able to get engaged and stay engaged with literally any task of your life, have you ever found anything you couldn't do? The vast, like 99% of adults with ADHD will say, no, if I can engage and stay engaged with something, I've never found anything I couldn't do. People with ADHD are omnipotential, is the word that's making its way out onto the internet. And so that's the problem, is that people with ADHD, when they get in the zone, is the slang here in Denver, it's getting the flow on the East Coast. When they really get engaged with what they're doing, they don't have any impairments. In fact, they're world beaters. They can do anything. And so that's the mystery and frustration of ADHD, is that the impairments come and go based on whether or not the person is engaged. And they get engaged in one of four ways. Yeah, they can do it if they're interested. They can do it if they're challenged or competitive. They can do it so long as it's new or novel, but that one's time limited. And they can do it when the task becomes urgent.
Right.
And those four circumstances, they can get in the zone and literally do anything. And then as soon as they lose that connection, they're off in la-la land. And so that teacher may be, again, because she's working one-to-one, constantly bringing them back to the situation, doesn't see the impairments.
That's interesting.
Because that's a setting in which you wouldn't. That's why ADHD doesn't show up on educational testing. Is the way the testing is done. You know, the person's sitting across the table giving them a new challenging thing to do, every 15 seconds.
Right. That was an eye-opener. Dr. Barkley mentioned that on a webinar, that neuropsych testing routinely misses ADHD and executive function disorders because the nature of the testing is just, he also, by the way, said, rating scales are the way to go. Yeah. Interesting. Here's a person, Raquel. She says, I've been diagnosed with depression, but I'm pretty certain that part of my issue is ADHD. What can I show or tell my psychiatrist to convince her that it might be ADHD? I mean, I think that story plays out day in and day out, I think, especially for women, frequently diagnosed with depression when it's actually ADHD. What can she do or say to her psychiatrist?
Well, you can get the diagnostic criteria and fill out the checklist. With the new Diagnostic and Statistical Manual number 5, adults only have to endorse 5 out of 9 of either set to get the diagnosis. And that's because 4 out of 9 is actually more than sufficient. So even 5 is more than you need. So,
right.
And you go in there and say, look, here it is. I've been having this trouble consistently as far back as my memory goes. You're going to run into a significant number of adult psychiatrists who know nothing about ADHD, and so consequently, they're lazy too. They just say it doesn't exist, and they will not acknowledge that the diagnosis is there, and it basically leaves you with only one thing to do, and that's go and find a new practitioner.
Yeah.
That's extremely common.
Yes.
And again, the question is, how do you find somebody? I always start with CHAD, the CHAD meeting, Children and Adults with ADD. Or I go to Attitude Magazine, has a referral section on the website of people who are good practitioners. But go and talk to people who have gone out there, who have found somebody they like. They can tell you who to go to, who not to go to. They can save you several years of messing around with people who don't know what they're doing. So go to people who have real life experience, and they happen to be a year further down the process than you are.
Right.
That's the best way to go.
Okay. I want to come back to something you said about switching a little bit now to treatment, about trying both the amphetamine class and the methylphenidate class of medications. Some people misunderstood that and thought that you were saying that people might take both medications. Can you clarify or talk a little bit again about the process that you go through to optimize treatment? Because I think this is an area where people have so many problems.
Sure. Yeah, it's one stimulant medication or the other, not two at the same time. Unfortunately, there's no universally accepted methodology for choosing a medication, fine-tuning it, and handling any side effects. So this is just what I personally use in my own practice. I use a target symptom approach. I list with the patient basically the things that brought them here in the first place. What are the things about their ADHD that they would like to get rid of that causes them impairment every day? And so it's going to be things like procrastination, not being able to get started on important tasks, easy distractibility, mind wandering, daydreaming, the inability to finish projects that you've started, the inability to read, that your eyes go over the page and nothing sticks. The inability to relax, to slow down, being impatient, easily frustrated. Again, it's whatever it is for that unique individual. Those are the target symptoms. And then I start people on the most reliable delivery system that their skin flint and medical insurance will provide. I don't use immediate release stimulants anymore if I can possibly get away with it. And we start at the very lowest dose. And so say if it was Vyvanse, we'd start at 20 milligrams. And again, what you see at 1 hour is everything it's ever going to do. These medications are completely effective in an hour. So you can, with adults, you can change the dose every day. So the first day is 20 milligrams, the next day is 30, the next day is 40. And what I want to know is how long is the dose lasting and how well is it managing the target symptoms that that person has. So you can just keep on increasing the dose so long as each time when you do increase it, all you're seeing is improvement and no side effects. So as long as things are just getting better and better, you can keep raising the dose. But at some point, you're going to raise the dose and go, I didn't see further improvement today. This dose and yesterday's dose seem exactly the same to me. At that point, yesterday's lower dose is the lowest dose that gives the maximum benefit and no side effects. And if you're over the age of 16, that's your dose for the rest of your life. Tolerance doesn't develop, except in exceedingly rare cases, to the benefit, the ADHD benefits of these medications. Then I will stop that one and I will go to the other medication and give that a try. And usually patients are very clear about which one they like best. So the old axiom is that the patient chooses the molecule and the doctor chooses the delivery system.
Interesting. So by delivery system, you mean
the time release mechanism.
Oh, I see. Okay. The time release medication. How often then should someone who's starting on an ADHD medication, whether a child or adult, plan to see their physician? And do you think that physicians are willing and able to manage this kind of daily change? I mean, I'm imagining that most are not.
Again, it depends on the age of the identified patient. Most people up to age 14 have a real hard time with self-appraisal. They really have a hard time being able to tell people what the medication's doing for them, to them, what the side effects are. So usually all that the mom is aware of is when a side effect occurs. Okay. That's where the teacher is very commonly invaluable, in that the teacher's asking the kid to do something that the ADHD nervous system struggles with, and that is sit there, be still, be quiet, and listen for extended periods of time. So getting feedback from the teacher is very helpful. So with people under the age of 14, I will only change the dose once a week, and every Thursday I will get the teacher to fill out a scale like the Connor Global Index scale, which is very good for monitoring progress on medication. With adults who are fairly able to look and see how they're doing. They have a spouse or a significant other who can also give them feedback. For those people, I change the dose every day, just boom, boom, boom. And we can do both medication trials in 2 weeks. So again, it depends entirely upon the age of the person and that ability for self-appraisal.
Got it. There is a new blood test apparently that helps determine what medication is right for you. Have you had experience with that or a point of view on that?
I personally think that's a lot of nonsense. Tone it down. I do not use them. I don't think there's any science to support it. It's the ability to very quickly and easily count these actual genes. Is when they make that leap that the genes that they've counted can actually predict response to medication. I have never found that to be true. I don't think the science is there, and I do not do gene testing.
Okay. Do you, a number of parents on the webinar say their child is on medication, but they have no other help with the other kinds of issues that are still on the table, organization, some of the executive function things. Is there, in your view, should behavior modification or other therapeutic help be given to people, either adults or children, who are on ADHD medication?
Yes. And when I said earlier that nothing but medication was working, it was for the ADHD, for those core symptoms of ADHD. Cognitive behavioral therapy and all that stuff really doesn't affect the core ADHD. That does not mean that it won't be helpful for the unique individual. It's just going to be what in the field we call non-specific benefits. And that means that anybody's going to do better in a structured, predictable, safe environment than they are in one that's not predictable, chaotic, topsy-turvy, unprotected, etc. So for kids with ADHD, the more routines you can give them, the more skills you can give them, the better. The problem is that most of the techniques that are offered are ones that work very well for people who don't have ADHD, people who are referred to as being neurotypical. Mm-hmm. The other 90% of human beings out there organize themselves, motivate themselves by completely other factors. They do so because the task is important, because there's a reward for doing it, or there's a consequence that they don't do, if they don't do it. If you talk to an adult with ADHD and you ask them, look back over your entire life, can you remember even one time in which the importance of the task all by itself ever once helped you? People with ADHD will get a big laugh and say, no, you're kidding? Not once. To me, the importance of the task is nothing but a nag. I know what's important. I like rewards, but I've never been able
to do it. Right.
Yeah, it's meaningless because it doesn't lead to my getting engaged. So if you look at most of the techniques and principles that people are offered, almost always they are things that work real well for people who don't have ADHD. Mm-hmm. For instance, I found only one organizational book, and I went through more than 40, that actually has a chance of working for people with ADHD. It's Susan Pinsky's book on organizing solutions. Wonderful.
Susan Pinsky is a great resource for people with ADHD. Yeah. And I also think Kathleen Nadeau's ADHD-friendly organization, some of her techniques. But I agree, the vast majority of the organizing principles just don't work for someone with ADHD.
Yeah, because
you can't do it again, right?
Yeah. The thing is that most organizational systems are based on two things that people with ADHD nervous systems don't do well, and that's importance, which they don't do at all, and time. Now, most people with ADHD have a terrible sense of time. And things, organizational systems like Franklin Covey, decide what's really important and stay focused on what's really important. I mean, it's a recipe for instant disaster.
What about neurofeedback? There is some evidence recently, I think, that there are some programs. We just had a speaker who's been doing research in Boston Floating Hospital, and is a real believer. Now, the definition of neurofeedback that she uses is quite rigorous, 3 times a week, at least 40 weeks, and only certain methods of neurofeedback. She's not talking about just general brain training, but she's got a specific kind of neurofeedback in mind. Are you in agreement? Are you still wait and see on that, or what's your feeling? It's a big commitment for families, and they really would like to know, if there's evidence that it's worth that kind of a commitment.
Yeah, I am not familiar with this particular person and technique that you just mentioned, but in general, the sort of standard textbook that's a review of what is known about ADHD is a book that was put together by Peter Jensen. It's called ADHD State of the Science Best Practices, and in there is a chapter on what they call alternative treatments. Mm-hmm. And really, by virtue of being in Chapter 13, alternative treatments, it means it doesn't work. And so they review all of the literature up until 2012, 35 years of research on neurofeedback retraining. And in 35 years, they had never been able to produce a single paper to show that it had any benefit at all. So with that type of track record, I can't recommend to my patients that they do something that can't demonstrate efficacy. So I do not do it.
Okay. Oh, this has come up from a couple of people. We recently had a terrific speaker on sensory integration disorder, and she talked about the overlap in diagnosis and treatment, and she felt fairly strongly that people with sensory integration disorder should not be given stimulant medications. Do you have any comment on that?
Did she say why?
I think she did. I just don't remember what the reason was. I
have never been impressed that there was any problem with that, and usually people do exceptionally well. Again, because it helps them not be bombarded by stimuli. It helps them really control and not be overwhelmed by everything that's coming in all at once. In my experience, I have found ADHD stimulant medication to be very helpful. So I'd be interested to know what she was saying. Yeah, with sensory integration issues.
Right. Sensitivity to sound, sensitivity to touch, sensitivity to light, the usual, those kinds of things she was talking about. And it is a commonly found with ADHD. So
yes, it is.
Lisa says, in all caps, sleep, need help with sleep, what to do? So this question leaks out. I'm going to repeat it to you.
Sure.
And yes, you said, what did you say, 97% or some significant
90 to 95%,
wow.
There.
Right.
Again, it's most people, very few doctors, are going to make the connection between insomnia at night and ADHD. For some reason, physicians in particular think of ADHD as being a school problem, a daytime problem that at 5 o'clock ADHD clocks out and says, see you tomorrow, as if, somehow you got a new nervous system for the rest of the day. What you hear from the vast majority of adults is that they have this return of hyperarousal when it gets fully dark, when the sun sets. And their thoughts bounce from one concern and worry to another. They physically can't get comfortable. They toss and turn. There's a slightly smaller group where they fall asleep just fine, but an hour and a half later, after that first whim period, then they're up for a couple of hours. And what you're seeing is the hyperactive component of ADHD. It is not consistent through the day. It tends, in adolescents and adults, tends to be concentrated in the early evening. So what you do is You fine-tune the stimulant medication, make sure you've got everything it has to offer, and then on a day when you can, lie down after lunch while you're on the medication and take a nap. Now, most people with ADHD are not nappers. They're too hyper-aroused, but they find that they nap just fine on their stimulant medication because it has that paradoxical calming effect. Then they know that they can take the medication right straight through the day, and it will help them to sleep. Everybody expects, because they're stuck on the notion that these, by happenstance, happen to be mild stimulants, it's going to keep them awake. And so much so that they never actually test it with that nap in the afternoon. Somewhere around 60% of my adolescent and adult patients take a full dose of whatever their medication is at bedtime because they sleep normally, if they do.
Okay.
Again, if people believe the medication is going to keep them awake, you can bet your bottom dollar they're going to be awake. So they really do need to test it out in the afternoon. Just all I ask is a half an hour, try and take a nap. Again, because most people with ADHD are sleep deprived, most people sleep fine.
Linda, who's on the webinar, just wanted to post a comment to Lisa, who asked a question about helpless sleep. And she said, please tell Lisa that our daughter had terrible, horrible sleep issues her entire life. We introduced 2 milligrams of melatonin and an hour and a half before bedtime and took away our use of electronics, and it worked amazingly. So there was a suggestion from Linda that may help. A couple of questions that are, again, there's many questions here, which I'd love to have time to ask you, but I want to just address some of the concerns of older adults. There are a number of people, and we're seeing this increasingly on the Attitude webinars, people in their 50s and 60s and 70s who are being diagnosed or beginning to have treatment and are oftentimes being told that there's a problem being treated at older ages, or having their physician who doesn't want to prescribe to someone at that age. Do you have any thoughts on that?
Better late than never. Again, the ADHD nervous system is the same nervous system throughout the life cycle. One of the problems is that just out of tradition, people stop doing research at 55. There's not a single research ever published in people over the age of 55, but nothing changes. It's still the same condition. They still respond to the same medications at the same dosages. I've got 4 people in my practice who were diagnosed and started medication after they were 80 years of age.
Wow.
And then the one thing that's different is they go through 3 phases. One is this elation that they finally have an explanation for their lives. It all makes sense now. Then they go into about a 5 to 6 week reactive depression of what would my life have been like if I had known this 70 years ago. And then they go into
accept,
it's a real active grieving. And then the vast majority of these folks get extremely energetic. It's what I call the times of wasting response. They say, I so regret having missed out on life up till now. I don't know how much time I've got left, but I'm going to use every second of it.
Wow.
And off they go. They just take off. It's incredibly gratifying.
That's really great. This is someone who's asking about her 72-year-old husband. Can he take stimulants if he's on medication for high blood pressure?
As long as his blood pressure is under control, there's no problem with that. Again, if you have the right molecule and dose, these medications have no effect on the cardiovascular system. So all you have to do is take a blood pressure before you start the medication, and then take blood pressure readings on each dose as you go up. As long as you're under your optimal dose, your sweet spot, it will have no effect on your cardiovascular system. You go 1 dose beyond your sweet spot, and the diastolic pressure, the second number in the blood pressure, will pop up 10 to 15 points, and you go, aha, we've gone just a little bit too high, and we lower the dose.
Right.
Yeah, but as long as cardiovascular disease is handled, you're still good to take the stimulants.
Is there any role, in your view, for non-stimulant medications for the, I guess the Strateras and the other non-stimulant medications that are offered for ADHD or are FDA approved for ADHD?
Well, there is one, Stratera. There are two in the pipeline. Stratera works a lot better for children than it does adults. We measure how well some medication or treatment works using a statistical calculation called effect size. And that's exactly what it says. And just about everything in medicine comes in between 0.4, which is barely but consistently detectable, and 1, which is very robust. In children, if you lump together all of the studies of Stratera, they come in at 0.7, right in the middle of the pack. Okay. As soon as you get to 17, 18 and older, you lump them all together, and the effect size is 0.44, barely detectable. And Stratera has a fairly heavy side effect burden. So, again, it depends on the person's age, mostly.
Okay. Here's a great question from someone. She says, what exactly do the ADHD medications do that addresses the symptoms of ADHD? How do they work?
Okay. We know for certain that it has nothing to do with stimulation. When you're at your optimal dose, you should feel calmer. You should not feel stimulated. You should not have insomnia or anything like that. In fact, it's a return to normative levels of functioning and no side effects. Real quickly, because the science gets real hairy in a hurry, they did a study about 20 years ago where they did positron emission tomography scans following methylphenidate and where it went in the brain. With methylphenidate, there's one way in which it's bent in space that has all the benefits. The other way just produces side effects. And so what they found was the beneficial form of methylphenidate got concentrated in only one nucleus of the brain. And it's right at the center of the brain, most inaccessible place on the planet. And it's a structure called the corpus striatum. The striped body is what it means. And your corpus striatum is your executive assistant. What it does in real time is it takes in everything neurologically, everything you see, you hear, everything you think, your emotions, your physical sensations, everything, and in real time assign a significance to it. About 100,000 things a second, and it sends only the one most significant thing up to your cortex for you to think about. Everything else gets handled. So the place to see your corpus striatum at work is when you're driving a car. Driving a car is the most complex thing that an adult ever has to do. And yet, we can do it largely without having to think about it. You know, we drive along, sing to the radio, think about what we're going to cook for dinner, because we all know that our corpus striatum is going to keep us and everybody else safe. We've all had the experience of driving along, not really paying attention to what was going on, and suddenly there's something in front of the car. And even before we can really process and figure out what it is, the corpus striatum's already handled it. Slammed on the brakes, swerved to miss them, look in the rearview mirror to make sure we're not pulling in front of a bus, and start to question that person's parentage in the twinkling of an eye. Just boom.
So it's a sort of a synthesizing area of the brain, or it's a...
Right. It's what keeps our thinking from being overwhelmed by 100,000 pieces of sensory information. Okay. So imagine that the corpus striatum's only working 99% as well as it might, and rather than the one most important thing being sent up to the cortex for us to think about, 4 or 5 things get sent up there with no significance assigned. That's how most people...
They're all equally important, right? Yeah.
Right, or unimportant. That's how people with ADHD nervous systems describe being off medication. I got 4 or 5 thoughts at any one time rumbling around for no apparent reason. The current theory is that just by dumb coincidence, amphetamine and one way of bending methylphenidate in space happen to look like a naturally occurring molecule that's only in that nucleus of the brain that's necessary for membrane stability. Has nothing to do with neurotransmitters or dopamine or anything like that. And it's basically stabilizes the membrane so the corpus striatum can work at 100% rather than 99%.
Wow.
That's what all of the data currently supports.
Is there a book that you would recommend that really explains ADHD at this level? I'm trying to think. I don't know of one.
Well, believe me, I wouldn't be spending my weekends trying to get this book ready for publication if I thought somebody else had already done a good job.
Yeah, no, it's not out there, is it? I mean, we need to do that. Common question here. We're running out of time, but I just so many good questions. People who are told that they can't be treated for ADHD and anxiety at the same time. Is that your experience?
That's not my experience, and it's certainly not what is found in the research literature. All the research literature is on children. There are 5 studies of kids with both ADHD and anxiety disorders, and what they found was that in 80% of children, the anxiety got better. In 10%, there was no difference, and in 10%, it transiently got worse, day or two, something like that. Mm-hmm. Again, anxiety and people are stuck on the notion that by happenstance these are stimulants, and so they think it's going to make anxiety worse. What people know, though, is that if you got the right medication and dose, you slow down, you calm down, you relax, and that's why in at least 80% of the cases, the experience of anxiety gets much better. Again, forget that these medications are stimulants. That is not how they work. Okay.
Dr. Dodson, thank you so much. I'm just going to read one comment here. This has been so helpful. I wish Dr. Dodson practiced in Rochester, New York, which is where Holly lives. So we wish we could clone him too. Thank you so much. We thank you so much for such a great common sense and helpful approach to the topic. Thanks, everyone, and goodbye.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.
Ever tried reading while jogging, cooking, or even juggling flaming torches? Yeah, it doesn't end well. But with audiobooks.com, you can conquer books without the circus act. Dive into over 450,000 titles, including more than 10,000 free ones. Get hooked on a bestseller, find your next obsession, or finally read that classic you've been avoiding since high school. And here's the inside scoop. Sign up today for a free 30-day trial and snag your first 3 audiobooks on the house. Sign up for your free trial at audiobooks.com/podcastfree today. That's audiobooks.com/podcastfree.